Hello, good morning. My name is Juan Echanove, and I'm going to talk about food security during quarantine. And the basic idea, the basic thing that I'm going to discuss today is that I strongly believe that ensuring access to food and water during lockdowns, during quarantines, is a must to avoid the spread of COVID-19 pandemic in Africa. By the end of March, beginning of April 2020, and according to official statistics, there is already almost 6,000 confirmed tested cases of COVID-19 across Sub-Saharan Africa, and close to 200 people have already confirmed to be died because of COVID. And the COVID-19 is already present in almost 50 African countries. So, as WHO already is confirming, COVID-19 is increasing exponentially in the region. The possibility of unreported cases is also a matter of concern, given the very weak healthcare systems of most countries in the continent, and they do have, of course, a very limited availability for testing the cases. Unfortunately, current evidence does not support the hypothesis that corona will spread more slowly in countries with warmer climate. So it is anticipated that the spread rates of coronavirus in Africa could be similar to those we have seen in China or what we see in Europe or in the US now. That basically means that Africa may start facing the severe impact of this pandemic as early as late April or early May or during May. The calculator developed by the University of East Anglia in the UK estimates that COVID-19 deaths in Sub-Saharan Africa may reach 2.6 million people based on a 50% total infection rate. The calculator applies the relevant mortality rates for each age group, and in that regard, the total death rates for Africa is significantly lower than in China or Europe or US, where the percentage of people who is part of that particular risk group, the elders, is higher, whereas in Africa, population is younger. However, the calculator does not consider the potential of higher than average mortality rates by patients with pre-existing medical conditions, particularly predominant in Africa, such as HIV-positive population, and there are 34 million people in Sub-Saharan Africa who are HIV positive. Although there is not yet specific information about the risk of COVID-19 in people with HIV, it seems that the HIV-positive population is actually more likely to require hospitalization for influenza-linked pneumonia. High levels of endemic malaria might also be a serious complication for COVID-19 cases. And this is very important to retain, the calculator does not consider neither that many COVID-19 fatalities that are avoidable in context of well-developed health systems like those in China or Europe or US will not be avoided in Africa. Many COVID-19 patients need respiratory ventilators for life support, and many more need access to intensive care units, without which they could likely die. And most African countries have very limited access to these facilities or this equipment. For example, Uganda has only 55 intensive care units and only 13 nurses in the whole country with training in critical care nursing. So, with high infection rates, the mortality rate in the region, in Africa, could in fact be much higher to what we see in Europe or China, and the total number of deaths might be as high as 5 million people. In short, African countries should not expect a mild version of the disease, and to avoid millions of potential deaths, it would be critically important to slow down the spread of the epidemic, to protect limited health resources so that hospitals are not rapidly overwhelmed, and to protect the vulnerable groups. A combined approach of physical distancing, including quarantine and schools closure, workplace measures, etc., is probably the most effective way at reducing the number of novel coronavirus cases. Social distancing is the term used by epidemiologists to refer to this conscious effort to reduce close contact between people, to minimize or to eventually stop community transmission of the virus. Introducing these social distancing measures early in the outbreak of corona delays the introduction of the pandemic to a country or an area and may delay the peak of the epidemic in an area where the local transmission is already ongoing, contributing to reduce the number of deaths. What has happened in China shows that quarantine, social distancing for the entire population via home confinement, and isolation of infected populations can contain the epidemic. The purpose of those drastic measures is to reduce the number of people each confirmed case infects. Should strict distance measures, including home confinement for the entire population, be applied in Africa in the same manner as in China or Europe or now in most US states, the infection rate of corona could be minimized in the continent to 10% or even below, given the still relatively early stage of the pandemic spread in the continent. And as per the East Anglia University calculator, that could mean that mortality rate could be reduced in Sub-Saharan Africa very significantly. Furthermore, that could also reduce the number of cases that could require intensive medical care and hospitalization, helping to avoid the collapse of the already weak health systems in African countries. Instituting quarantines is a measure of last resort, but one that in the context of COVID-19, Africa will unfortunately have to apply. Quarantine involved restricting people's liberty and freedom of movement, as well as the access to their livelihoods and healthcare and food and water. International human rights law requires that any restriction to human rights in the name of public health should meet certain requirements, which are laid out in the Syracuse Principles. These Syracuse Principles said that the states imposing these measures have the burden of justifying such serious measures. They must demonstrate that the restrictive measures are necessary to curb the spread of the infectious disease. And although quarantines have been praised by WHO, the World Health Organization, as a means to reduce the spread of corona, the possibility of imposing these measures in less developed countries, like African countries, raises important questions. We have to keep in mind, anyway, that quarantines have been used effectively in Africa in the past to contain the spread of Ebola and other infectious diseases. In 2014, under the threat of Ebola, a number of rural communities in Sierra Leone successfully kept out cases of the disease through community control of local borders. Reduction in the number of Ebola cases in certain areas of Sierra Leone was largely attributed to quarantine strategies. But there were also significant challenges and also ethical considerations. Home confinement may cause severe negative impacts, including insufficient access to food and medical care. People need to secure their livelihoods during quarantines. And this is why the Syracuse Principle said that when quarantines are imposed, governments have an obligation to ensure access to food, to water, to healthcare. With modern supply chains, home delivery services, etc., and also with governments able to guarantee basic incomes during a certain period, countries such as China or Italy or Spain have been able to impose home quarantines for many weeks already that are now successfully flattering the spread of the disease and reducing the number of further potential deaths. But in Africa, for most people, no work means potential starvation, for many within a matter of days. The World Health Organization recognizes that if a decision to implement quarantine is taken, the authorities should ensure that the quarantine setting is appropriate and that adequate food, water, hygiene provisions can be made during the quarantine time. Since the end of March 2020, many African countries have started imposing lockdowns and social distancing norms, often in a non-planned and very disordered manner. In DRC, a 3-week lockdown imposed in Kinshasa had to be postponed amid fear of price speculation on basic goods and increased insecurity in the city. In Kenya, excess use of force deployed at the beginning of the curfew aimed at combating the spread of the virus resulted in shootings and deaths, and the government of Kenya has already apologized for that. In South Africa, also at the beginning of the quarantine, police shot rubber bullets and water cannons to disperse homeless people lining up for food. And similar situations have been also reported in Uganda, Zimbabwe, and various other countries. As it has been written recently in an media article, currently, the only model available to governments in this part of the world is restricting movement, but this has already backfired spectacularly. On the other side of the spectrum, some countries in the region have been slow to respond. Until Burundi recorded its first 2 cases on March 31, the government claimed it was protected from the virus because it put God first, and Tanzania refused for quite too long to undertake some basic control measures, such as closing massive gatherings for worship. It's clear that top-down curfews that don't consider the needs of the people during the lockdown, the quarantine, are not an option. Neither is an option not to act. Countries in Africa require a feasible social distance measure model that can avoid the spread of the pandemic while ensuring the basic livelihoods of the population at the same time. As we said, during the 2014 Ebola outbreak in Sierra Leone, quarantines were imposed on individual houses, but also on neighborhoods or villages, and in a few cases, even in entire administrative districts. In practice, in most cases, these quarantines were normally lasting for some 3 weeks. In the community quarantine model, the movement of people is limited to accessing basic services and going to work with the limits of a certain geographical area, generally the village, including the farmland around. The use of this community quarantine proved very helpful in holding back the 2014 Ebola outbreak in Sierra Leone compared with the household quarantine. Because in community quarantine, community can still continue accessing the water resources and the fields and keep farming activities ongoing. So village-level community quarantine means that movement restrictions apply to communications with those outside the village, which are limited to cases of emergency, but not within the community, excepting in the case of symptomatic or tested positive cases, which should undertake home confinement if the symptoms are mild, or have to be referred to health facilities if they require intensive care. Given that most rural communities in Sub-Saharan Africa are engaged on primary production, community quarantine allows to preserve basic food security during the lockdown period, which should normally take, as I said, 4 to 6 weeks. However, certain disruptions in the food supply are probably unavoidable. Most rural communities depend to one extent or another on external food to ensure nutrition diversity. Income may be disrupted given the inability to reach the markets outside the community. Finally, access to seeds, fertilizers, and other agricultural inputs can be affected during quarantine weeks. But in any case, all these negative impacts could be even more intense in an scenario of household-level quarantine. We also need to keep in mind that we are not talking about several months of quarantine, but some weeks, and that not ensuring social distancing means the threat of millions of potential lives lost. More than 80% of the food in Africa is produced on smallholder farms, so ensuring that the farmers can continue producing during the quarantine weeks is critically important for food security during the recovery phase as well. Hence, the area for free mobility within the community should include the farmlands, pasture lands, water sources, and other means of production. The experience from the Sierra Leone Ebola pandemic demonstrated that involving local leaders during planning and implementation can help ensure community needs are met. It will also be important to announce the start of the quarantine well in advance for communities to stop production, to preposition themselves, and prepare for this period of isolation. Fundamental human rights should be respected, and as I said, access to basic supplies should remain possible during the quarantine. Village-level quarantine is not a perfect solution, but is a realistic model to push back the pandemic expansion while preserving the basic rights of the communities and avoiding the much higher impact on the food security of the population that household quarantine or household confinement may entitle. Finally, it also provides better living conditions, helps social distancing for in-house suspected cases, and reduce the impact of gender-based violence compared to household confinement, and somehow also preserves to keep the social cohesion fabric of the community, because some level of social interactions can still be maintained at the level of the village. The village-level community quarantine model should be applied as early as possible once community transmission of corona starts in a territory. And by a territory, I mean either a country or, in case of large countries, the specific portion of the country where community transmission has started taking place. Governments and donors, and I will talk later further about this, should start now providing production means to the rural communities in Africa, seeds, fertilizers, storage equipment, etc., to enhance the ability of the community to remain self-sufficient during the quarantine period. Most households in urban Africa depend on daily wage. So, I think there are two main continent-wide initiatives that Africa urgently requires right now. On the one hand, a massive program to supply seeds, fertilizers, and other means of production aimed to support rural communities to undertake community village level quarantine when needed and where needed. Cash or vouchers could be distributed to smallholders across Africa in the relevant regions. I estimate that at least $3 billion could be needed for this. So 50 million smallholder farmers could get at least $60 per household in terms of this very necessary aid. And second, a cash or vouchers or food aid program or a combination of those to cover the basic food and water and hygiene needs during quarantine for at least 50 million African households living in conditions of extreme urban poverty. Funding requirements for this could be estimated in at least another $3 billion. That could mean 30 days confinement for 50 million people with a daily ration per household of at least $4. Implementing these initiatives will require decisive political will by African governments and the full support of the international community. They will also require, as I said, mobilizing very fast, significant financial resources. And the cost of these initiatives, although very significant, via the joint effort of the main donors, the World Bank, the African Development Bank, IFAD, USAID, EU, and other donors could probably be matched. Plus, if governments in the region could make budgetary allocations, particularly if debt relief can be granted to countries in Africa right now, so they can have the fiscal room, the fiscal space to allocate budgetary resources right now for undertaking these initiatives to secure the food for the poor during quarantine. There are probably still a few weeks window of opportunity, maybe 2 months maximum, to contain corona in Sub-Saharan Africa, but unless decisive measures are undertaken immediately to secure the food security of the poor, it will remain impossible to implement the type of social distance measures that are needed to contain the pandemic, and millions of lives can be lost. Thank you very much.